Good evening and welcome to Doctors on Call. What would you like to know about upper GI problems like heartburn, indigestion, ulcers, gallstones, abdominal pain? I'm Dr. Ruth Westra from the Department of Family Medicine and Biobehavioral Health at the University of Minnesota Medical School, Duluth. Call locally at 218-788-2844 or toll free at 1-877-307-8762. We have a medical panel ready to answer your questions live. I'm pleased to welcome our panelists, Dr. Brad Irwin, a gastroenterologist with St. Luke's Gastroenterology Associates, Dr. Ken Ripp, a family medicine physician with the Raiter Clinic in Cloquet, and Dr. Theresa Smith, a gastroenterologist with Essentia Health. Answering our phones tonight, we have our medical students, Nathan Nelson from Alexandria, Minnesota, Catherine Rogers from Roberts, Wisconsin, and Casey Smith from Gallup, New Mexico. And now on to tonight's program. So we'll have a couple questions. We'll just talk a little bit before the questions come in. So we had talked a little bit about dysphagia, and maybe Dr. Irwin, tell us what dysphagia is.
In a very simple way, it's just difficulty swallowing. So dysphagia can be a lot of different things. It can involve trouble swallowing more in the cervical esophagus where people are choking. A good example would be a stroke patient or a patient with neuromuscular disease that's choking. And it can be esophageal, meaning there's a problem within the esophagus causing difficulty swallowing. It could be a tumor or another condition causing issues there.
Well, Dr. Ripp, how would we work that up? Somebody comes in and says they have a hard time swallowing.
If it's in the clinic, usually it's a history that's just gradually coming on of saying, over time I'm finding food gets stuck. And if they're starting to get to the point where food gets stuck and then they're starting to vomit or that happens at all, then we usually involve one of our gastroenterology colleagues and they'll go down and take a peek and see if there is a stricture. If it's acute, occasionally, when we see them in the ER, then we're calling them in at night to come and remove that obstruction from them. A lot of times there's some medicines in the ER that sometimes can help things pass through and then they can see them in a more controlled setting.
Anything to keep it from happening over and over again, Dr. Smith?
Well, I would say if someone's having that type of difficulty, they should get it checked out because you can run into the situation like Dr. Ripp described where something gets stuck and it won't pass, and that can be very uncomfortable. It can also in rare situations lead to some serious damage to the esophagus, even rupture of the esophagus. So if that were to happen to someone where they felt like something got stuck and they couldn't get it down after a few minutes or so, they really should seek medical care. They should go to the emergency room and they would be evaluated, and if these medications don't relax things enough to let things pass, then they will call in someone to take a look with a scope. And sometimes we're able to just kind of gently push whatever is stuck down into the stomach, but at other times we have to remove whatever it is that's stuck in the esophagus. And then we generally assess the esophagus to look for what the cause was for the food getting stuck. It's not normal to get food stuck. So oftentimes we'll find a stricture, a narrowing in the esophagus that we can stretch open. Or there is a condition called Eosinophils Esophagitis that we're seeing fairly frequently now in young people. Many years ago, it was typically middle-aged or older people that would get food stuck from strictures, from acid reflux, or rarely from tumors. But recently we've been seeing a lot of young people with this eosinophilic esophagitis, which is an inflammatory condition in the esophagus that in some individuals can be related to food allergies and can be treated with a diet or with topical steroids to decrease the inflammation.
Oh, fascinating. So Dr. Ripp, do we have any good screening tests for esophageal cancer? Would that difficulty swallowing lead to esophageal cancer?
If someone has persistent problems with dysphagia, eventually they're going to lead to getting a scope, which is a camera going down to look. Because we worry about esophageal cancer be the worst, but there's some precursors to that. One of them being Barrett's esophagus, which is simply a movement of some cells from the stomach up into the esophagus, and that has to be monitored. And so our hope is to, diagnose that and then screen people and hopefully fix any problems long before they get there. For the routine general population, there's no recommendation for routine screening for esophageal cancer because it is luckily a fairly rare cancer.
Yeah. So talk a little bit more, Dr. Irwin, about Barrett's.
Yeah, Barrett's is a condition where the normal squamous lining of the esophagus is replaced with a more intestinal type of lining, and it's due to chronic acid reflux. And we typically see this in patients that have sort of long-standing reflux. They may have small sliding hiatal hernias that give them more reflux. Barrett's in and of itself is kind of a precancerous condition in that if it never changes and does anything, it'll just stay the same. Mm-hmm. But Barrett's can then progress to Barrett's with dysplasia, both low-grade and high-grade dysplasia, and that's a step towards cancer. So the goal of screening endoscopy in patients with Barrett's, on average, we probably repeat these about every 3 years, is to look for biopsy and sample that Barrett's epithelium and make sure they don't have any dysplastic features. And if they do, treat that aggressively with ablation so it doesn't have a chance to actually progress into cancer. With that, we tend to recommend still pretty aggressive acid suppression. Mm-hmm. It's controversial somewhat. The studies have been off and on as to whether or not aggressive acid suppression really does reduce your risk of esophageal cancer in Barrett's. I think for the most part the consensus still is to do that and treat it aggressively so there's not as much inflammation in the background of Barrett's because that inflammation may drive that or make it change into cancer faster. We see Barrett's quite frequently, probably more commonly in middle-aged Caucasian men, but we also find it in women quite frequently of all ages, and younger people more and more as well. So.
Oh, that's really helpful. But you talked a little bit about acid suppression. Maybe Dr. Smith, you could tell us about medications that we might utilize for that, and maybe some conversation about PPIs.
Sure,
would be
sure.
helpful too.
There's a host of different medications that can be used to treat heartburn or acid reflux. The common ones that people buy over the counter would be things like Tums or Rolaids or liquid antacids. And those are fine to use if they work and you're not having to take them frequently. The next step up would be medications in a class of drugs called the H2 blockers or histamine blockers like Zantac, Pepcid, those types of things. To be effective for acid reflux or heartburn, they have to be taken twice a day, and they're not nearly as effective as the next category up, which are the proton pump inhibitors. And that would include things like Prilosec or omeprazole is the generic name for that, or Nexium. There's a whole family of these drugs. And essentially they're chemically very similar and work the same way. They block the pump in the stomach that produces acid. And they have been somewhat controversial recently because there's been some mounting evidence that long-term use of those medications could lead to some chronic problems like chronic kidney disease, osteoporosis, vitamin B12 deficiency. And it's controversial. There are some studies that suggest that long-term PPI use could be associated with Alzheimer's, and then there are other studies that refute that. So there has been a movement recently to try and get people off of those medications if they don't need them. Probably where everyone should start with treating acid reflux disease is lifestyle modifications, because if you can control your symptoms with just making some changes in your diet and your activities, that's really the healthiest and the best way to manage the symptoms. And then if that's not working, you can kind of work your way up the ladder of medications. And then surgery is also an option for treatment of long-term acid reflux. There are techniques, surgical techniques that can be done to tighten the junction between the esophagus and the stomach to help keep food and acid down in the stomach. So for those individuals who can't get off of their proton pump inhibitors, they might want to be considered for surgical treatment.
Well, Dr. Ripp, we're starting to get some calls, so we'll transition a little bit to that too. So this is a caller from Duluth asking about Gerd, which we've kind of been talking about a little bit, but also getting a cough related to Gerd. Can we talk a little bit about why that would be happening and kind of a burning sensation?
Yep. So if the valve that's supposed to keep the stomach contents out of your esophagus isn't working well, and some of those contents are able to make it all the way up and trip over into your airway, you will get a chronic cough. It is probably the second or third most common cause of chronic cough is reflux. And so often if people come in to see us and they have a chronic cough and we rule out asthma, a lot of times we will just put them on something to suppress their acid and it takes unfortunately a couple months to improve it, and sometimes that can help with that chronic cough for people.
Same kind of medications.
Same, yep. And then once again, lifestyle modifications for some people. If it's a cough at night or in the morning, a lot of times raising their head up, making sure that they're avoiding things that loosen up that sphincter. So coffee, caffeine, chocolate, unfortunately, alcohol, mint, different things can make that muscle more prone to open up and allow those contents to come up. Red sauce, so.
Lots of things to potentially change.
Yes.
So Dr. Irwin, this is a caller from Duluth asking about sleeping at night and then waking up in the morning and kind of having more of a coating on their tongue.
Mm-hmm.
So probably similar, but let's talk about that a little bit.
Similar, absolutely. So obviously, just thinking about it from a mechanical standpoint, the times when you're going to reflux the easiest are when you're lying down flat in bed. Also possibly lying on your right side as opposed to the left. It makes it easier to reflux stomach contents. If they're like me, they tend to eat late at night, and obviously when you do that, food's in the stomach's going to make acid and fluid to help digest that or break that food down, and then you go lay down, and those normal barriers may not be good enough to prevent the reflux from coming up into your esophagus, throat, and into your mouth. Traditionally, call it sour brash or a funny taste in the throat or mouth. People wake up with that. Can be an indication that they're having nighttime reflux. Couple things, obvious things we recommend is obviously not eat late. Give yourself about 4 to 6 hours between bedtime and when you eat meals. If that's not effective and you're still refluxing and you're looking for another lifestyle modification, then we recommend elevating the head of the bed about 4 to 6 inches, actually the whole bed at a slant, and not using excessive numbers of pillows. Pillows can actually cause more compression on your belly and cause more reflux, so we like the whole bed elevated or at an incline, and a wedge can also help prevent that. And of course the medications still, one of the medications that we'll use either in conjunction with or solely would be an H2RA, like a Zantac or a Pepsid at bedtime, because they don't depend on food to work well.
Well, thank
Yep.
you. So let's talk a little bit too. There's a couple callers asking about, are ulcers more common in the fall or spring? Dr. Smith, have you ever heard anything like that?
Yes, there does sometimes seem to be sort of a seasonal association with flaring up of ulcer disease, and I don't really have a good explanation for why that might be. We now know that the majority of ulcers are caused by one of two things, and sometimes those two things in combination. There's an infection, a bacterial infection that can occur in the stomach called Helicobacter pylori, or H. pylori for short. And that infection markedly increases the risk of ulcers in the stomach or the bulb of the duodenum. So if someone has a history of ulcer disease, it's a good idea to make sure you don't have that infection, because that can be cleared with antibiotics. And then probably the more common cause that we see are medications like aspirin, Aleve, Advil, those types of things. Those medications, if used chronically, can cause ulcers. If you have the infection and are taking those medications, then you're at very high risk of getting an ulcer. So if you do need to be on those medications long term, it's probably, and you have a history of ulcers, it's probably a good idea to get checked and make sure that you don't have the infection and get rid of that first before taking those medications long term.
So Dr. Ripp, there's some callers, everyone can kind of jump into these, because I've got 2 or 3 questions about the proton pump inhibitors as well. So one, Dr. Ripp, is a caller from Duluth asking about if you have kidney failure, do you suggest using Prilosec?
With Prilosec, it's not contraindicated in kidney failure. With patients who need that medication, if you have Barrett's, you're probably going to be on that for life. because esophageal cancer is a bad thing. If your doctor puts you on omeprazole, and this happens quite frequently, someone comes in, they get put on it at one visit or in a hospitalization, and then it just never gets taken off. And I think what the campaign is to tell primary care doctors is, see if you can get them off. See if you can step down from omeprazole down to one of the H2 blockers like Pepcid or Zantac. And a lot of people can make that transition easier because then you're not getting the risk associated. Now, the risk of proton pump inhibitors is small, but when you look at thousands of people, then you're going to see increases of osteoporosis or maybe pneumonia or other things. But I think you need to work with your physician individually to see if it's right. If you can get off it and you don't need it anymore, great. And so if you need to use Tums once or twice a week along with some Pepcid once in a while, and that takes care of all your symptoms, that's great. So, but some patients need to be on it for a prolonged period. Renal failure is not a contraindication to omeprazole.
Good. Any other added comments for that?
No, I agree 100%. You obviously, if the kidneys are really advanced, you can dose reduce the medication, but just like Dr. Ripp said, just a lot of folks do need the medication, so we definitely use them.
Well, Dr. Irwin, they're also asking about if you are starting like over-the-counter meds, like if you have heartburn or symptoms, how long should you try over-the-counter meds before actually coming in and complaining to the doc about your experiences?
The labels generally say about 2 weeks. If you're using them daily for more than 2 weeks, it might not be a bad idea to visit with your primary care physician, because that seems to indicate something's changed. They're not really meaning the patient that goes out and has a pizza and has heartburn. That's not uncommon and doesn't necessarily herald a bad thing. But if it's daily, no matter what you're doing diet-wise, that could signal something worse going on. And rather than taking the medication and forget about it, we don't want to, if you have something that we can fix and correct before it becomes worse, we certainly want to get on that. So.
Okay. Well, Dr. Smith, this is asking about apple cider vinegar. Does it cause heartburn?
Does it cause heartburn?
Right.
I've had several patients tell me they're taking it to prevent heartburn. I don't really understand how it's a. So vinegar is a mild acid. So I don't think from a physiologic point of view that it makes sense that it would help with heartburn, but I have had people tell me that they feel much better doing it. It's probably harmless, so if it makes you feel better, I'm okay with that. But I don't really understand why it would help.
Okay. Dr. Ripp, a caller is asking about gallstones, so we'll switch a little bit here. Has a history of gallstones, had an attack a few months ago, but really hasn't had any problems since. What's the consensus? Should the gallbladder come out or not?
Well, I guess it depends on how bad the attack was. If the attack was enough to land the person in the hospital for a week, then I'd say probably that gallbladder should come out, because you never want to do that. Now, if you had an episode where maybe your stomach didn't feel so good and maybe didn't feel so hot, and you went and your doctor ordered an ultrasound and they saw some gallstones, that gets a little more vague. So it's really going to be, are the gallstones causing enough symptomatic problem where you need to get it taken out? If you had one little episode of belly pain and you've never had anything else, and you can eat a fatty meal and it doesn't bother you in the least, then you probably don't need your gallbladder out. Now, if you drive past McDonald's and your belly starts to hurt, then, and you can't look at mayonnaise or anything fatty, then you probably should start thinking about doing that. Now, sometimes there's other testing. If the ultrasound isn't, there's other testing that we can do to test the function of the gallbladder to see how well it's squeezing and stuff like that. So it's really is, if you're having a lot of recurring symptoms, you definitely want to talk to your doctor, because it may be time. If you,
Good answers, thank you. Dr. Irwin, I think we talked a little bit about this, but there's another caller asking about hiatal hernias and surgery. Any surgical recommendations for those?
Yeah, that's a little bit tough. I'd say the lion's share of hiatal hernias I encounter on endoscopy are small sliding hiatal hernias. And I generally recommend everything we've talked about so far, lifestyle modifications, even weight loss, and doing things to prevent your reflux that way. But there are a lot of folks out there that no matter what we do, medications, lifestyle modifications, weight loss, etc., still have a significant amount of heartburn, and that's usually what drives this. Then we'll go ahead and recommend surgery to correct their hiatal hernia. And there's a lot of very good techniques now, laparoscopic techniques that are minimally invasive with very little complication rate. There's other kinds of hiatal hernias that can be more serious, where the stomach actually comes up and makes a kink or a twist. And sometimes they get stuck and actually like strangulated hernia, and those actually do need to be operated on sooner than later so the stomach's not damaged. Not super common, but it can happen. But in essence, I think most of the hiatal hernias, at least I encounter, are small and can be handled without surgical intervention.
Very helpful. Well, Dr. Smith, there's a caller asking about gastric ulcers and familial cancer. Can we talk a little bit about gastric cancer a little bit and risks related to that?
Sure. There are genetic mutations that can markedly increase someone's risk for gastric cancer, as well as colon cancer and lots of other types of cancer. So if someone has a strong family history of stomach cancer, it's certainly worth discussing that with their physician. They may want to have you see a genetic counselor to talk about the genetic tests that are available. So gastric ulcers most of the time are not cancerous, but they can be cancerous. So generally when we find a gastric ulcer, and this is a little controversial, it used to be kind of gospel truth that if as an endoscopist, if you found a gastric ulcer, you were obligated to go back and make sure that ulcer healed. That's not quite as strict a recommendation now as it had been in the past, as opposed to duodenal ulcers, which are fairly, very, very rarely cancerous. So we generally don't go back and document healing of a duodenal ulcer. And that's a more typical location for ulcers to form. But yes, if you know that you have several family members, and by several I would say 3 or more, or at least 3 total in the family that have had stomach cancer, then it's definitely worth considering genetic counseling.
Mm-hmm. Very good, thank you. Dr. Ripp, this is an interesting question, so maybe others will want to jump on this too, because it's talk about stomach polyps. What does it mean if you have a lot of stomach polyps? How would you find those?
The only way you would find that is on endoscopy, if they're looking down in there. And so a polyp is just simply an outgrowth of tissue off the normal mucosa. So it's just a little button of skin that's sticking up. Mm-hmm. They can be benign, or they can be a harbinger of changes that can go anywhere from dysplasia, which is abnormal tissue, all the way to a cancer. And so a single polyp of itself probably is not an issue. If you have a lot of them, that means that there's probably something different about how you're designed, and that does probably raise your risk of developing a dysplasia or a cancer.
Mm-hmm. And is there any familial polyposis or things like that that might
there are familial cases, and unfortunately those people often know their parents and then will know about that, and those people will get screened earlier and more frequently.
I had an interesting question about tattoos and the relationship with any difficulty swallowing or anything. If you had tattoos on your neck or anything associated with that, that was.
Boy,
I'm going to say unless you. I'm going to say I've never heard of that unless you're having a reaction to the ink or the dye or something like that.
Some kind of swelling that might happen too.
Yeah.
So.
It can be an issue if you get MRIs because they can get hot.
Mm-hmm. Mm-hmm.
So they use the wrong ink.
So Dr. Irwin, just maybe one more question about foods. Like if you're having difficulty swallowing, is it related more to liquids or more to meats? Someone was asking that question.
It's usually more solid food, and it's the drier foods. Dry bread, chicken, and meat are the things that I tend to encounter on my food impactions. So somebody is having some issues swallowing or has poor motility, for instance, in the esophagus, make sure they drink fluids, chew their food very well, and eat slowly. But it's usually the dry stuff.
That'll help a lot.
Yeah.
And maybe one more question about NSAIDs, our care with nonsteroidal anti-inflammatories, just a brief comment about those related to stomach issues, Dr. Smith?
Well, they certainly can cause gastritis, inflammation of the stomach. They can cause ulcers. So if people are taking large quantities and frequently, they could be predisposing themselves to problems. So certainly, and that's not the only problem. They can cause, taking NSAIDs long-term can cause kidney problems as well. So if whatever you're taking them for isn't getting better in a fairly short period of time, you really should discuss that with your primary care doctor to see if there's some alternative treatment rather than just self-treating with those medications.
Very good, very helpful. Well, thank you. Our time went very fast. I want to thank our panelists, Dr. Brad Irwin, Dr. Ken Ripp, and Dr. Theresa Smith, and our medical student volunteers, Nathan Nelson, Catherine Rogers, and Casey Smith. Please join Dr. Ray Christensen next week for a program on lower GI problems when his panelists will be Dr. Waldo Avello, Dr. Robert Erickson, and Dr. Daniel McKee. Thank you for watching. Good night.